So our last speaker then before refreshments, I'm absolutely delighted to introduce Marion Gounelle, who has completed her Master's in Clinical Psychology, specialising in clinical psychopathology and neuropsychology of aging. Marion has completed much training in the areas of clinical neuropsychology, law and health, art, music. She's currently working at the PROPA Neurological Centre in Montpellier, working with individuals with neurological disorders following a spinal cord injury, head injury, stroke, or neurodegenerative or developmental pathology. Marion is also doing a PhD in health psychology, and she also works in association with COMET France to promote the socio-professional reintegration of people with disabilities. So today, Marion is our Anette Johansen-Quale ESPA Scholarship recipient. So we would like to present this award to Marion. And she's going to talk to us today about the validity and reliability of the French Self-Efficacy Scale.
Thank you, Claire. Hello, everyone. It's an honor to me to be here and to receive the Anette Johansen-Quale Scholarship. I would like to thank to the ESPA for giving me this opportunity today. I know you just must be afraid or impressed to standing in front of me today, but don't worry, it's going to be fine. So, firstly, I would like to take a quick poll. How many French-speaking persons are in the room? Thank you for your participation. But even if there is no many French speakers here, no one, I hope that the process of a cultural adaptation of a scale and on another language and the validation of its psychometric propriety will interest you. Before standing, I would like to point out that I have no conflict of interest. Okay, this way. Okay, as you know, after a CI, persons are faced with a subsequent challenge and must become actor to their own rehabilitation process. They have to reconstruct themselves and to become more confident in dealing with their injury. But psychological disorders are common, and they influence quality of life and individuals' behaviors. We know that in this population, there is a significant risk of secondary disorder, including infection, chronic or neuropathic pain, spasticity, pressure ulcer, or drug addiction. So individuals with SCI present a high risk of rehospitalization, comorbidity, and mortality. Care management in rehabilitation center aims to minimize loss and trauma by improving the patient's autonomy and quality of life. So a person with SCI needs to become more knowledgeable in order to understanding and manage their new condition, even if they feel uncertainty regarding the future and experience loss and perceive life control. Furthermore, it's essential for them to learn to recognize the warning sign of complication in order to develop new protective health behaviors. Studies suggest that developing self-efficacy can have a positive effect on anxious and depressive disorders and on secondary health complications. Self-efficacy is a specific cognitive process which contributes to psychological adjustment after spinal cord injury because it modulates behavior according to the patient's belief and confidence in their own ability in challenging situations or once eliciting stress. Self-efficacy influences motivation, decision-making, and ability to act on set on personal goals. So it also facilitates the achievement of goal, investment effort, and persistence on the long term. And self-efficacy is strongly associated with optimism, self-regulation, and self-esteem. individual beliefs regarding the ability to succeed in certain tasks and achieve goals can predict the adoption of behavior to maintain good health, improve health, or reduce complication. This confidence is dependent on their belief, as you know. Self-efficacy can influence coping strategies because they promote the adoption of healthy lifestyle, and as the gene presents, the different level of self-efficacy can be identified: a general self-efficacy, domain-specific self-efficacy, or task-specific self-efficacy. Following SCI, persons need to apprehend the new physiological and functional change in their body. This can be a source of trauma, stress, and anxiety. The subjective symptoms dramatically affect a person's sense of personal efficacy and identity. The interplay of psychological disorders and distress, the interplay of psychological distress and personal efficacy contributes especially to the resilience process. So self-efficacy acts on a set of biological factors: the physiological response to stress, the immune system, the activation of neurotransmitters, and the secretion of endorphins. Studies suggest that increased self-efficacy could have a positive effect on secondary health conditions because it might predict the intention to adopt healthy behaviors. Consequently, we can say that self-efficacy contributes to the quality of life and well-being after SCI. Generally, people with high self-efficacy perform better in problem-solving and in decision-making. So in case of difficulty, they can maintain their efforts and their perseverance. Persons with high self-efficacy and a strong sense of control over their disease will present a lower risk of addiction, weight loss, and cardiovascular disorders. A greater level of satisfaction with life, well-being, and perception of important social support. A greater level of independence and functional improvement, decreased pain, less spasticity, etc. When individuals feel able to achieve their recovery goals and use self-control strategies in challenging situations, their quality of life will be almost equivalent to people in general, and they are more likely to experience success. In contrast, people with low self-efficacy tend to give up if they face an obstacle and can become depressed and anxious. Depressed people feel unable to complete tasks and are less able to perform in certain activities of daily living. While anxious people approach situations with apprehension, which reduces their efficiency. Consequently, persons with low self-efficacy and SCI will have an increased risk of developing psychological disorders such as depression, anxiety, and stress. They will experience more pain and present an increased spasticity. We can say that low self-efficacy influences the risk of comorbidity and the mortality because low levels of self-efficacy are associated with long-term complications and decreased psychological well-being. Measuring the self-efficacy can be an indicator to monitoring the process of self-appropriation of SCI. It can help to identify patients with high risk of mental disorder and secondary health condition in order to refer them to counseling or therapeutic education. Measuring self-efficacy can help to assess the individual's capacity of self-care and to adjust rehabilitation goals and provide additional support, follow-up, and outpatient monitoring. So, it seems essential to have behavioral tools to identify patients who present a low self-efficacy. In 2020, Van Diemen compared all these 4 scales. They are presented in this slide. You can see Scherer General Self-Efficacy Scale, the Self-Efficacy Scale, the University of Washington Self-Efficacy Scale, and the Mooring Self-Efficacy Scale. So, the findings of this study reflect the complex nature of the 4 scale. So far, very few self-efficacy scales used in the SCI research seem sensitive enough to detect change over time. And the result of this study strongly suggests that it is because most self-efficacy scales tap into this general latent conscious or aspect of SAE self-efficacy trait rather than domain or task-specific effect of self-efficacy. But the most commonly used self-efficacy scale in SCI research is the Mooring Self-Efficacy Scale. It was originally developed to measure state aspects of self-efficacy. And the MSES was being found to be a reliable and valuable measure for people with SCI. And it seems relevant and adapt for use in your practice in France. If some person don't know what is a Mooring self-efficacy, so it's a 16-item scale evaluating the level of confidence in performing everyday activity in person with SCI. The scale exhibits good statistical properties with a good convergent and discriminant validity in different cultures and across different social conditions. The international consistency is strong, and the scale was strongly correlated with quality of life, satisfaction with life, mental health, and physical health. Here are presented the different dimensions of the MSES. First of all, the original scale had 2 dimensions, daily activity and social functioning. But later, Brooks and al. Found 3 different dimensions of the MSES. Interpersonal self-efficacy, instrumental self-efficacy, participation self-efficacy. However, item 10 and 14 were removed from the scale to form this dimension. They are presented here on the left part. Yes, and for Middleton and al. On the right, you can see that there are 2 dimensions which are specific to SCI, personal function self-efficacy and social function self-efficacy. The third represents a more general self-efficacy in activity of daily living. For these authors, trust for Middleton and al. For 3 items were delighted to contribute this dimension. Although Brooks and al. and Middleton and al. don't not reach a consensus regarding those dimensions, and the distribution of item by dimension, or which item should we keep. So, the objective, the first aim of this study was to translate and adapt the MSES into the French language and the culture. The second objective was to determine the psychometric properties of this new scale and its dimensional structure. We conduct a multi-center cross-selectional study in France. But first of all, we did a French translation We use a back translation process, and it was completed in partnership of Professor Middleton and his team. This step was required in order to produce a translated version in French that was as close as possible to the original version of the scale. Secondly, SCI expert committee was formed with 3 clinicians and 2 psychologists in health. They were asked with Delphi method and we searched to establish a consensus between the 5 experts using a Delphi method, including guidelines in the development of post-disaster psychological evaluation, like 10th guideline. So, experts were screened with a structural questionnaire, and its relevance in patient care. Their opinion and their overall impression of the questionnaire were gathered using a Likert scale from 0 bad to 7 excellent. A minimum of 75% of agreement were expected between all the experts. 2 consensus rounds were conducted, one before and one after the acceptability study. The acceptability study of the pre-final version was conducted on 8 persons. It was an open pilot study in the center of Propa. People were consulting during their stay, and they have to respond to the same structural questionnaire that experts have to complete. For the result of the French translation, 2 cycles were required to complete the translation of the scale. The content validity and the acceptability of the lead to several adaptations to the tool. First of all, experts reformulate the item in order to highlight the feeling of self-efficacy. Therefore, most items start with I feel able to. Patient and experts suggest to changing the scoring system in order to facilitate the answer. Therefore, it was revised into a 5-point Likert scale from 1 not confident at all to 5 extremely confident. Some participants asked us to clarify the issue of domestic score and to broaden the participation in the management of administrative tasks and in parenthood. Participants reported that the scale was easy to use and was relevant for the assessment of well-being and self-efficacy in persons with SCI. In all, the acceptability score was 85% for patients and 82% for experts. Patients had an overall positive opinion of the questionnaire, and they reported that it accurately identified difficulties faced with autonomy and reflected current state of mind. So the version resulting from this synthesis served as a basis for the next stage. So we made a validity study, and we recruit participants in 6 physical medicine and rehabilitation centers in France. You can see where are they in the card here. Potential eligible patients were identified by PMR and physicians during their initial or secondary stay in the centers, and patients in secondary inpatient stay or among outpatient consultation were recruited. Each participant received clear information and accept to participate in the study, of course. And people were included with a traumatic and non-traumatic injury, SCI for longer than 3 months, and if they are aged between 18 and 70. They were excluded if they were severe cognitive or psychiatric disorder, poor understanding of French language, or presented an unstable medical condition. So, participants were recruited from June 2018 to September 2019. All clinician data were collected in person or in online with a platform which name is RedCap. We assumed that the French version of MSES would be strongly related with the general measure of self-efficacy, quality of life, mental state, psychological resources, and autonomy. We expect that person with low self-efficacy and will report a poor life satisfaction and be at higher risk of anxiety or depression, while exhibit lower resourcefulness. Here is the material used for the validity study. I won't go through in each detail, but it was the list of the material that we used, and let you take your time to read it. So for the material for the reproducibility study was assessed on a sample of persons with SCI admitted to a rehabilitation center for their initial SCI care. The self-questionnaire was administered twice at 4-day interval, and all items were randomized in order to decrease the risk of memory bias. The following goodness of fit statistics were used for the cross-cultural validation of the MSES-Fr are presented here. I will be happy to talk to anybody in detail for later about this statistical analysis if someone wants or not. Okay, let's go for the results now. First of all, I present to you the population study. Here is the demographic and injury-related data. In all, 226 people were approved to participate in this study, and 201 were recruited. The first sample, which participated to the validity study, is here on the left side. It consisted of 157 men and 45 women with SCI. Mean age is 48. Most of them attained a bachelor's degree and did not have a partner. The majority of them had a paraplegia and for more than 10 years. For the second sample, you can see that the majority of participants were men with a bachelor's degree too, and many of them were in a relationship. Regarding to the medical data, most of them were have a paraplegia since 1 year ago, and the cause was principal traumatic. For the confirmatory and expectory factor analysis of the MSES, we want to see if the repartition by dimension was the same as Brook and Al, or the same as Middleton and Al. So we compare this, makes different confirmatory and exploratory factor analysis. You can see on the table that there is a historic of them. So for the Mooring Self-Efficacy Scale in French, you can see that the key two, is low. The RMSEA is under 0.08, and the CFE is superior to 0.90. That is good, fit indices. And just the TLI is under the score expected, sorry. There is the item dimension, repetition by dimension in this figure, and results indicate that the three-dimension model as identified by Brooks and al. Yield better statistical indexes compared to those obtained by Middleton and al. So, three-factor image in your sample. The instrumental self-efficacy. It includes the feeling of self-efficacy regarding activity of daily living. The interpersonal self-efficacy dimension encompasses the feeling of self-efficacy perceived by person with SCI in their interpersonal relationship and leisure activities. The participation self-efficacy dimension measure the perceived feeling of self-efficacy in work-related situations like life fulfillment and maintenance of good health. Here is a table with the results of the validity of the MSES-Fr and the presentation of the total score and the dimension score. Many numbers. Here, what we can say that the results of the international consistency of the MSES-Fr were excellent. The Cronbach alpha is 0.87. For the total score of the MSES-Fr, the convergent validity was strong with a GSE, General Self-Efficacy Scale. There were moderate correlations found between the total MSES-Fr score and psychological measures like self-esteem, ability to handle with stressful situation, mental health, like anxiety, and the sensation of being overwhelmed. Fair negative correlations were established between the total score of MSES-Fr and depression score. No specific correlation were observed between the MSES-Fr total score and the social support score, the coping strategy, age, educational attainment, and medical variables. Okay, for the reliability study, it was conducted on a sample of 56 individuals, mean age 47. We assume that the MSES-Fr to be a reliable psychometric instrument because it produced the same results in the same time for the same person at two close time points. Sorry. We complete a first test on day 1 and on day 4. The intra-class coefficient is strong. It's a 0.74 for the total score of the MSES, validating a good reproducibility of the scale. The kappa score are shown in this table for each item and each dimension. Your results are substantial for 3 items, moderate for 6 items, and fair for 6 items. Only one item, the item I can accomplish most things I said to do, exhibited an insignificant degree of concordance between the test and retest situation. Maybe it's about the situation and this feeling changing every day for patients. So, what's happened now. Okay, it's okay. Oh, I don't push so strongly that I have to. Okay, for the discussion of this study, the first objective of this study was to adapt the Mooring Self-Efficacy into the French language. And for the culture, the adaptation of the scale was an important part of this study. Using a Delphi method with a both expert and person with SCI, it facilitated the development of a strong instrument. Based on the recommendation of expert and patient, we decide to simplify the scoring system. Our results show a three-dimensional model with, as described by Brooks and al. And for your sample, it was most appropriate. This repetition by dimension was most appropriate. Okay, perfect. And the second objective of this study was to validate the propriety of this scale and to explore the validity. Results were satisfactory with good internal consistency, convergent validity, and reliability. The MSES-Fr show a significant but moderate correlation with other related psychological constructs, such as mood, self-esteem, and perceived stress. This result reflects the fact that MSES-Fr explores domains of psychological functioning and does not focus on level of impairment, disability, or bodily function. The global reproducibility of the MSES-Fr is very good and similar to the original scale, and the reliability per item vary widely, which suggests the importance of the global score rather than an item per item interpretation. But this study has so many limitations. All these results might have been influenced by the choice of the scale. As such, we use generic scale and non-specific to person with SCI in this work, because in France we don't have many scale in this language. However, additional studies are needed to more specially refine these elements within the French population. And to improve the recruitment and follow up your sample for the reliability study was consisted in person of the initial phase of their hospitalization, and it may be interest to access the reproducibility of the scale on a larger sample. Then the impact of cognition wasn't studied. And so we can conclude that further studies are needed to assess the scale's responsiveness to change. So, in conclusion, the MSES-Fr assessed dimension of relevance to SCI rehabilitation and can help healthcare professionals improve the ability of persons with SCI to self-manage the new condition. And it can also facilitate the identification of at-risk patients. The measurement of self-efficacy can help therapists to develop self-management programs in order to adapt treatment and prevention. And measuring self-efficacy at different times of the therapeutic course can help set personal priority goals and treatment adaptation. Enhancing self-efficacy can promote self-management behavior by improving feeling of control and self-awareness, which can reduce SCI-induced distress and anxiety. Thank you. Yeah. Yes, I want to say that it's a global effort, and this is my team and my partner here. Thank you very much.
So thank you so much to Marion for that excellent presentation. Anybody have any questions that they'd like to put to Marion before we break for some refreshments? Yeah, fine.
Probably I missed it. Thank you for the presentation. Probably I missed it, but when we investigated the neuron, then we saw that we also find 3 dimensions in our sample. But these dimensions had a very high correlation with each other. So the question is, can we actually speak of different dimensions, or should we see it as one scale? What's your opinion about that?
A difficult question. Yeah.
Repeat the question to the people.
How can you?
So Time, your question was about the different dimensions of the scale and whether it should all be grouped together?
Yeah, the correlation is so high.
Okay.
You can ask if they are really separate dimensions.
Okay, so are the dimensions really separate because the correlation is so high?
Maybe it's because they are not so separated, but you know, you spoke about the general trait aspect of self-efficacy, and sometimes one of item could be in another dimension. So the analysis give us this result, but I think that we can improve the measurement of self-efficacy in addition other item. Maybe for the future, it can be interesting to develop a new measurement, a new version of the Mooring Self-Efficacy with a new item on the management of their medication, their pressure ulcer, the welfare, this kind of specific element. And maybe we should have very strongest link between the dimension and more separated concept.
Did you talk about this with James? I found it very hard to do.
We can speak to this with pleasure. Thank you very much.
Thank you, Marion. So I think we're going to take a refreshment break now. So a quick stretch outside, and we might try and keep it short just to stay on track, if that's okay. There's refreshments that are actually set up in the back of the room. So if people want to go for a stretch and then return to the room with their refreshments, that would be great. Thank you, and well done, Marion.
Thank you.